Bismillahirrahmanirrahim. So the next topic in nephrotic syndrome is focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis is one of the most common cause of nephrotic syndrome in the adults in United States. It is primarily a disorder of the podocytes, which results in the damage to foot processes, causing flattening of podocytes. So the disease is typically characterized by the presence of sclerosed glomeruli. So let's break down the nomenclature. Let's say these are the glomeruli. Focal means involving a very few. So let's say this is the glomeruli that is involved. So 1 out of these 5 glomeruli are involved and 4 are normal looking. Segmental means only a small part. So in this case, this glomeruli is involved. And what happens here is that only a specific portion of this glomeruli is sclerosed. The rest of the glomeruli is normal, and a small portion or a segment of this glomeruli is sclerosed. Hence the name focal segmental glomerulosclerosis. So FSGS can be either primary, which means it is idiopathic and the disease lies within the kidneys, or FSGS can also occur in association with certain other diseases such as HIV, heroin addiction, and in sickle cell anemia. The secondary FSGS means that there is some other disorder such as in IgA nephropathy, a chronic inflammation to glomeruli results in sclerosis. So secondary means another disease causing the FSGS. There are also some genetic factors which contribute to inherited forms of FSGS. So coming on towards pathogenesis, there are certain genetic factors and some unknown circulating factors in the blood which damage the foot processes of the podocytes, resulting in flattening of the podocytes, and they also damage the endothelial of glomeruli, resulting in increased permeability. So endothelial damage and podocytes flattening results in increased filtration of protein across into the urine, causing proteinuria. And some proteins also get entrapped within the glomerular foci, which result in the increased extracellular matrix deposition, causing sclerosis of the glomeruli. The extracellular matrix is also deposited along the afferent arterioles, causing hyalinosis of afferent arterioles. So these arterioles become thickened and tough instead of having flexible walls. So the genetic factors involved in the focal segmental glomerulosclerosis primarily affect the filtration slit. So this here complete is a filtration slit. This is the endothelium of the glomerular capillary, and this is the basement membrane. These are the foot processes of the podocytes, and there are specific proteins present between these foot processes which together form a filtration slit. So the first mutation is in NPHS1 gene, which encodes nephrin protein. This here is a nephrin protein. The other mutation is in NPHS2 gene, which encodes podosin. This here is podosin. And the third gene that is involved is a gene encoding podocyte actin binding protein, or alpha actin 4. So mutation in any of these three genes result in the loss of structural integrity of the filtration slit, which makes the podocytes flattened because of the effacement of these foot processes. So once these foot processes become effaced, there is an increased filtration of proteins from the capillaries into the urinary spaces. Another gene that is mutated is TRPC6. This gene encodes a calcium channel which is present on the cell membrane. So mutation in this gene results in abnormal calcium channel, allowing increased influx of calcium ions into the cell, which damages the foot processes and flattens the podocytes. So all of these genetic mutations result in the effacement of the foot processes, making the podocytes more flattened, allowing the proteins to filter across filtration slit into the urinary space and resulting in proteinuria. Coming on towards the morphology, there is segmental sclerosis of few glomeruli, which means most of the glomeruli are normal. This here is a glomerulus, as you can see, And this is the segment that is sclerosed, whereas this portion over here is normal looking. Sclerosed glomeruli contain collapsed capillaries, and there is excessive extracellular matrix deposition along with increased plasma proteins. There is also hyalinosis of the afferent arterioles. Hyalinosis is basically due to the extracellular matrix deposition along the afferent arterioles, resulting in decreased flexibility of the capillaries, which ultimately leads to hypertension, which is a sign of focal segmental glomerulosclerosis. So due to increased permeability, lipid droplets are also present along with the foam cells. As you can see here, this is a lipid droplet. Foam cells are actually macrophages which are loaded with the lipids. The electron microscopy reveals effacement of the foot processes of the podocytes. The effacement is diffused, which means it involves all of the podocytes. There is a difference between diffused and focal. Diffuse means involving all or completely involving. And focal means a small part or a small region. So there is diffused effacement of the foot processes of podocytes, giving them a more flat appearance. Immunofluorescence microscopy also reveals IgM or C3 antibody antigen complexes in the sclerosed glomeruli and in a normal looking mesangium. The presence of IgM and C3 antigen antibody complexes denote the immune nature of the disease. So focal segmental glomerulosclerosis presents in children as well as in the adults. The disease prognosis is better in the children, whereas it has a very bad prognosis in adults. The disease presents with hematuria, which is more than in minimal change disease. Proteinuria might be minimal or it can range up to nephrotic syndrome. Proteinuria is non-selective, which means all proteins can cross into urinary space and into the urine. Hypertension is also present due to the hyalinosis of afferent arterioles, and these patients also present with azotemia. The diagnosis is on the clinical signs and histology report of the biopsy, and treatment is with immunosuppressants such as steroids. 20% of the cases of FSGS progress into end-stage renal disease within 2 years of the onset, which means they need dialysis and renal transplant. So in 25 to 50% of the transplant cases, recurrence has been noted, which indicates the involvement of unknown circulating factors in the blood. So a 32 years old male with the periorbital swelling and hematuria presents in the clinic. Proteinuria is 3.8 grams per day, which is of nephrotic range, and there is azotemia as well. A provisional diagnosis of FSGS is given. What is the hallmark of FSGS on histopathology? So the hallmark of FSGS on histopathology is that there is presence of sclerosed glomeruli along with the normal looking glomeruli, and even in the sclerosed glomeruli only a part of the glomeruli is sclerosed, whereas the rest of the glomerulus is normal. The most common genes which are mutated in the slit diaphragm include NPHS1 gene, which encodes nephrin. Then there is NPHS2 gene, which encodes podocin. Then there is mutation in a gene encoding podocyte actin binding protein, alpha-actinin 4. There is also mutation in the calcium channel gene known as TRPC6. So proteinuria in FSGS could be minimal or it can be as much as in the nephrotic syndrome. Proteinuria is non-selective, which means all the proteins, whether they have a small size or large size, can filter across into urinary space and into urine. So that brings us to the end of the discussion of focal segmental glomerulosclerosis. If you have any questions, do let us know in the comment section. Thank you.